Hello everyone and welcome to our lecture over the respiratory system. The first half of this lecture we're going to be talking anatomy. Second half will be physiology. So structure first and we'll talk about function. So what it is, how it works. First of all, the respiratory system works very closely with the circulatory system. A common question you may see on standardized testing could be something related to which of the following functions works with both the respiratory and the circulatory system. So the answer here would be O2 and CO2 exchange between the lungs and the blood, right? This overlapping piece, number two. So functions overall of the respiratory system are obviously breathing, right? Number one, breathing. And this gas exchange that happens with the blood, the circulatory system, and this overlapping zone right here on number two is going to be super important, and we're going to talk about a lot. Then the circulatory system takes that oxygen, that CO2, into the blood. And then the circulatory system is also in charge of the exchange between the blood vessels and the tissues of these gases. So be prepared to see an image like this on the exam, or at least be prepared to label something like this. So you have this nasal cavity space up here, right behind the nose, that you'll need to know. The nostrils are just the openings. That's it. It's not going to be any of the inside. The inside is the nasal cavity. So nostrils are the openings and nothing further within. The nasal cavity is what's within. The pharynx starts up here behind the nasal cavity, and it goes down all the way until the larynx begins. And we'll talk pharynx some more because the pharynx is divided into three different parts. The oral cavity is the inside of the mouth. The larynx down here includes the epiglottis, which is the little flap that covers the trachea. The epiglottis ensures that anything that you're eating or drinking don't go down into your larynx, don't go down into your trachea. So if you're talking and you're eating at the same time, so think about it as you're swallowing and you're trying to breathe at the same time, your body's going to get confused. And that's when you can get choked on a piece of food or a crumb or something. That's when you say, oh no, it went down the wrong pipe, and you're trying to cough it out. That's because that happened because the epiglottis was opened when it should have been closed. But that's because you were eating and breathing, trying to talk at the same time. You were doing both, and you shouldn't have been. So your body got confused. It opened up at the wrong time, or the epiglottis opened up at the wrong time, which can make you choke. The trachea, right here is the windpipe, and it splits inside the chest. So it goes to your lungs, and that split right there goes to the left and right primary bronchus, or main bronchus, whatever you want to call it. Left, right. Remember, patient left, patient right. The split, this little Y, is called the carina of the trachea, so it's got its own fancy name. The Y is the carina. But then we go into our left lung over here. So the left lung has two different lobes. One lobe, two lobes. The right lung has three different lobes. Lobe 1, lobe 2, lobe 3. So why is this? Why does this lung have more lobes than the left lung? So notice this little space right here, this little carve out. What do you think sits right there? That's the heart space. That's where the heart sits. So notice that the left lung is a little bit smaller. It's got it, and it only has space for two lobes. Because of the space for the heart that's needed, right? So we talked about that in the heart lecture as well. Diaphragm, this curved muscle down here is the diaphragm, which allows you to breathe. Without this diaphragm, you would not be breathing. So in the respiratory system, you have two major zones. The respiratory zone and the conducting zone. So the conducting zone is just the air passageway. It's the path from your nose and mouth to your lungs. The respiratory zone is where the gas exchange actually happens, down in your bronchioles, which are the little tiny passages that we'll talk a lot about, and the alveoli, which are the little air pockets down there, which we'll also talk about a lot. So conducting gets the air in, respiratory fires up the gas exchange, if you want to remember the difference between the two like that. I don't really have an easier way to remember it, but conducting, pathways to gas exchange, so air in to from your nose and mouth to your lungs, and then respiratory zone, respiration, that's the site of the gas exchange. Now respiratory muscles, diaphragm is the major one, but we do have other muscles we call accessory muscles that help you breathe. So some people, when they breathe, their shoulders go up. That is wrong. That is not the right way to breathe. Any musician that you talk to are taught to breathe in with their belly. And we call this abdominal breathing, which means you breathe in the air and push it down to the bottom of your lungs, which pushes your diaphragm down, which makes your belly pooch out. If your stomach isn't pooching out, you're breathing wrong. You're not getting the max amount of air, the max volume of air that you need to promote ventilation. The nose. Why is the nose important? The nose provides an airway. It also moistens and warms the entering air. So think about when it's cold outside, you breathe too hard, especially if you're a mouth breather. The air isn't passing through the chambers it's supposed to, and you haven't moistened or warmed that air coming in. So you essentially cause yourself to have a brain freeze or pain inside of your chest. The moral of that story: breathe through your nose when it's cold outside. The nose helps, moisten and warm everything coming in, preventing any brain freezes or headaches or chest aches. The nose also filters and cleans the inspired air. So you'll see inspiration, that just means inhaling or breathing in. So it cleans inspired air. The nose hair actually does this. So it's okay to clip your nose hairs, but don't pull them out all the way. Your nose hairs are little filters, and they filter out bacteria and pollen, insects, if you will. All of those things usually end up as boogers. So don't eat those. Don't let your kids eat those. Eating boogers is gross. That's everything that's not supposed to be inside of you. So don't put it inside of you by eating it. Breathing through your mouth also does not allow you that same filtration system. So if you are breathing through your mouth a lot, all that junk that your nose is filtering is going straight to your lungs if you're breathing in through your mouth. The nose also, the nose also serves as a resonating chamber for speech. So think about when you have a stuffy nose and you can't say the N and the G sounds. So this acts as a vaulted ceiling. So how sound just rings through a vaulted ceiling, like in a cavern, in a cave, maybe in a church, in an atrium. All of that is called a resonating chamber, and that's what your nose is. That's basically what your nose functions as. So resonating chamber for speech. Finally, your nose houses all of your olfactory receptors. What is olfaction? Olfaction is smell. So this is your sense of smell. So those come through the roof of your nose, through the cruciform plate of your skull, which we will look at shortly. So everything that is in red, you will be expected to know, and you will be expected to be able to label should it come up on your exam. So the cruciform plate, that's right here. So those are the holes in the skull. Nerves come down through those little holes into the epithelial layer in the roof of the nasal cavity. So this big baddie right here, the nasal cavity that we just talked about. The sphenoid sinus is right here. Be able to label that. We'll talk about that a little bit more shortly. And now we have the pharynx, which is broken up into three. Remember, you have the nasopharynx, the oropharynx, and the laryngopharynx. So first, the nasopharynx. This houses the pharyngeal tonsils. They're tucked up in that corner. Opening of the eustachian tube, where the fluid in your ear drains. And then the uvula, the little dangly thing in the back of your throat. So remember we talked about the pharyngeal tonsils and the eustachian tube in a previous lecture. Remember, if these tonsils swell up, remember what we discussed? They prevent ear drainage, so they cause middle ear infections, right? And sometimes doctors will opt to remove those, the pharyngeal tonsils, to keep ears draining for people who have a lot of middle ear infections. So it's a different tonsil removal than the one that we're used to with our palatine tonsils, right? Okay, so moving on. We've already talked about that in a previous lecture. Next is the oropharynx. So nasopharynx is down to the uvula, and then we have the oropharynx begin. So the oropharynx is behind the mouth. So oral, mouth is a way to remember that. So in the oropharynx, we have the palatine tonsils right here. And you can see those in the back of your throat. Those are the ones that you know. Those are the ones that you're used to. Those are the ones that you're used to getting removed, or your friends having their surgery for removal, or you yourself have gotten removed. Then we have the lingual tonsils. Those are at the base of the tongue. You cannot see those. They're right above the epiglottis, which we will talk about a lot. So epiglottis is right here. If you ever feel a lump in your throat, it could be that your lingual tonsils are swollen. Just FYI. Right there at the back, at the base of your tongue. That brings us to the third part of our pharynx, the laryngopharynx. So the larynx is in there, right? The parts you need to know here are the epiglottis. So that important little flap we keep talking about, right there. Notice that the trachea is down here. The epiglottis covers it, right? It makes sure that your windpipe doesn't get food or liquid particles into it, so you don't choke. So the epiglottis covers the hole that leads to the trachea, which is the tube to the lungs. So don't get the esophagus confused with the trachea. The esophagus goes down to the stomach, the trachea goes to the lungs. Let's see, what else do we have here? We have the thyroid gland. You guys should be able to point out where that is after talking about it in the endocrine chapter. We have the thyroid cartilage. So some people with a big thyroid cartilage are said to have an Adam's apple. So that should clue you into its location, right? Think about where the Adam's apple is located. Inside of the larynx, we have vocal cords and vocal folds, and we will discuss how that impacts the size of the thyroid cartilage. Let's see, start at the top. We have our frontal sinus right in the forehead. So think sinus cold, sinus headache. That's sinus pressure on this frontal sinus in your forehead. It's located right between your eyebrows, that little flat part. You should already know the nostril. Shouldn't have any difficulty pointing out where those nasal openings are. Know where the hard palate is? That's the ridged part behind your teeth. That's where it starts. So if you follow that back with your tongue all the way until it gets that little soft part, all that hard part, starting at the ridged part behind your teeth up to the smooth part, that's also hard. That is your hard palate. The soft palate, your tongue can reach, and you can feel that change from hard to soft. So that's where the hard palate ends and the soft palate begins. It is softer, as the name indicates, and it allows for bigger opening for when you're swallowing, so it'll expand a little bit more, allow you to swallow down some food or drink. The tongue, you guys know where the tongue is. I'm not going to talk about where the tongue is. If you don't know how to label the tongue, then, you know, we have some issues. But last on this slide is the hyoid bone. So this is the only bone that's not attached to another bone. It is attached only to muscles. It's actually U-shaped if we looked at it anteriorly, but we're looking at the lateral head and neck structure here. All right, paranasal sinuses. In the previous picture, you saw the frontal and the sphenoid sinuses. Those are called, like I said, the paranasal sinuses. We have two more. The ethmoid is going to be under the eyes, and the maxillary is going to be in the cheekbones. So if the doctor is pushing on your cheekbones or on the sides of your nose, on your maxillary and your ethmoid sinuses, they may ask you if they feel tender. If you answer yes, then that tells the doctor your sinuses are inflamed and you probably have sinusitis. And actually, depending on the color of your snot, that will determine whether or not it's bacterial or viral, and then the doctor will be able to tell you what to do. You'll get prescribed antibiotics for bacterial infections, but for viral infections, sometimes you just got to power through those, take meds to mask the symptoms, right? So you're not in pain. Because antibiotics are not going to do anything for a virus. So if you are somebody that's like, oh, I have a viral infection, I need antibiotics, you are wrong. You are the problem. Overprescription of antibiotics causes antibiotic-resistant bacteria. You can also hear these called superbacteria. That's a conversation for a whole nother day. I don't want to get into because I will go on a giant tangent about overprescription of antibiotics for things that are actually viral, which is not good because it's not going to do anything for you. But anyways, just remember, antibiotics work only for bacterial infections, not viruses. Let's get back to sinuses. The sinuses perform a couple of functions. They warm air as it goes through, as you breathe in, but they also help lighten the skull. So if all the bones in your skull were completely solid, your head would be really heavy, right? So sinuses lighten your skull by about a third. And then as air moves through the sinuses, it picks up moisture. So when it's really dry outside, you don't have much moisture, it can cause headaches or sicknesses. So no moisture to catch bacteria, sends it straight to the lungs. Similar to the lack of nose hair that we just discussed. Humidifiers can help with this. It can help keep the moisture level up in dry areas of your house. Humidifiers, not dehumidifiers. Dehumidifiers take the moisture out of the air. Humidifiers put it back into the air. Interestingly enough, when it is too dry, your body will overcompensate with mucus production to make up for the lack of moisture that you're inhaling, right? And that can also cause more snottiness in drier seasons. Humidifiers can help with that, help with all the snottiness and excess amount of mucus production, right? This is regions of the pharynx more zoomed in. So these are the three zones that you need to be able to differentiate between. These are a little bit more color coded for you right here. The nasopharynx, oropharynx, and the laryngopharynx. The larynx and epiglottis, we meet again. So know that the epiglottis, it's an elastic coverage, covers the laryngeal inlet during swallowing. So that food and drink can't go down the trachea. That epiglottis covers that little opening and ensures that the food and drink go down the esophagus to the stomach like it's supposed to. Remember, it is an elastic cartilage flap, so it covers that little opening to the laryngeal inlet, which sits right above the trachea. Another zoomed in photo, you don't need to know most of this, but we will talk about vocal folds shortly. So this just gives you kind of an idea of where they are housed. Vocal folds right here behind the thyroid cartilage. So those are going to be your main two. Thyroid cartilage, vocal folds, true vocal cords. I'll probably call them vocal cords, honestly. But vocal cord, vocal fold, you could call it either one. Voice production. So males have a lower voice than females as they age. Little boys have a higher voice, and in their early teens, they go through a voice change that causes their voice to jump between higher and lower sounds, right? So that vocal change happens as hormones are kicking in. So as these are kicking in, they're starting to develop male characteristics, and one of those developments that is happening are some organs are starting to enlarge, right? So specifically here, we are talking about the larynx enlarging. And when the larynx starts to enlarge, the vocal cords that are stretched across the opening of the larynx are going to get longer. So think music, think string instruments. A violin with shorter chords is way, way higher sounding than a cello with a lot longer chords, right? So there's more to it than that, but it's a good way to remember vocal cords are similar. So the shorter, the higher the pitch, the longer, the lower the pitch. So longer vocal cords require a bigger larynx. That bigger larynx is going to stick out, and that is what we call an Adam's apple. So yay anatomy, yay science. See how all of that connects. Anyway, that was a segue. Let's get back to voice production. So we have speech. You can read the definition here. Intermittent release of expired air while opening and closing the glottis. So essentially, as you're blowing air out, it's passing over the vocal cords. The glottis opens and closes. The glottis is the gap between the vocal cords. So as the air comes out through the air between the vocal cords, you're going to make sounds. And depending on the pattern that sound is making is what we call speech. So if you don't change the opening and closing of the glottis, then you don't make speech. You only make what we call a sound. Sound is shaped into language by the muscles of the pharynx, by the muscles of the tongue, by the muscles of the soft palate and lips. But if you do open and close the glottis, then you make speech. So when you change the shape of the pharynx, the tongue, the soft palate, and the lips, that makes individual language. Whereas speech and sound, are differentiated there. So make sure you know the difference. Pitch is the highness or lowness of the voice. So remember, the shorter the vocal cords, the higher the pitch. The longer the vocal cords, the lower the pitch. The longer the vocal cords, the bigger the Adam's apple, essentially, in males. Loudness. Loudness depends on the force of the air. So I use a lot of forced air over the vocal cords, which makes me loud. If you just whisper, you're not using a lot of forced air, so you're a lot quieter. I tend to be on the louder side of that one. The chambers of the pharynx, oral, nasal, and sinus cavities, they amplify and enhance sound quality. So think about people who can and can't sing. So some people just don't sound good. It could just be the fault of their anatomy, and you can't change that. The actual tone of your voice can be changed, but you can't change the different pitches or sounds overall. Your anatomy dictates the tone of your voice, right? All right, so let's continue on. Let's talk conducting zone structures. So you have the trachea that splits into the left and right main primary bronchi. So remember, the conducting zone is how you bring air in. The respiratory is the gas exchange. Conducting is bringing air in. So anyway, the trachea splits into the left and right primary bronchi or main bronchi, whichever one you say is right. It's fine. Primary or main. Now, the right main bronchus is wider in diameter, it's shorter, and it's more vertical, so more up and down than the left side. So that means that the left is more narrow, longer, and more horizontal. Correct? I was going to say right, but that would have been confusing. Think about why the bronchus on the left side would have to be more horizontal. So what's in the way? The heart, right? The heart is in the way on the left side. The left lung is going to be smaller to house that heart, and it's going to have a little bit, branching is going to be a little bit different because of where the heart is sitting. So if a kid were to inhale a bead or something that they shoved up their nose, which side do you think that the bead would land? The right or the left bronchus, main bronchus? So it's almost always going to be the right side, because as that bead is inhaled, it goes straight down, and then the right side continues going straight down, where the left would have to make a 90-degree turn, a side turn. So going straight down is going to be a lot more simple than making a 90-degree turn into the left bronchus. From there, the main or primary bronchi branch off into smaller ones. In this case, there are 2 on the left and 3 on the right. Again, because the heart is there, the left lung is only going to have 2 lobes and secondary branches that go to each lobe. Same as the right side, except for the right side has 3 lobes with secondary bronchi, secondary branches that go into each of those 3 lobes. So here's a visual. Got the trachea going down the middle. Left and right primary bronchus here. Left and right primary or main bronchi. You'll have one heading to the inferior lobe of the left lung, right here. And then you'll have one heading to the superior lobe of the left lung. So you only have 2 lobes on the left side. You have 3 on the right side, so you'll have one secondary branch that leads to the superior lobe of the right lung, one that leads to the middle lobe of the right lung, and then one that leads to the inferior lobe of the right lung. So you'll have a superior, a middle, and an inferior secondary bronchus. And on the left side, you'll just have a left superior and a left inferior secondary bronchus. Respiratory zone time. So this is where the actual gas exchange happens, and that starts with respiratory bronchioles. Starts there, moves to alveolar ducts and alveolar sacs. The respiratory bronchioles are the tiniest branches off of the secondary bronchioles. Primary bronchi are the biggest and the thickest. You can basically stick your thumb in those. The secondary are smaller. We didn't talk about the tertiary, but the tertiary are the next branch down. And then last but not least, you'll have the respiratory bronchioles, then the alveolar ducts, and then the alveolar sacs. Those look like little clusters of grapes at the ends of the respiratory bronchioles. So here's what that looks like. Terminal or tertiary, same thing, right? So if you say terminal, it's fine. If you say tertiary, it's fine. Bronchioles are first here, branching to the respiratory bronchioles, and then the alveoli are hanging off of them like grapes. Clusters of grapes. Remember, those are the alveoli. Alveolar ducts lead to the alveoli, and a cluster of them are called alveoli sac. If you cut through a lung, then you'll see all these little air pockets. These tubes are the respiratory bronchioles. They lead to the alveolar ducts, which lead to the alveoli and the alveolar sacs. So all the little globs are going to be alveoli sacs and made up of the alveoli. So right here you can see the alveoli pores. And then all the perfect little circles that you can find here, the ones that look like perfect little circles, those are going to be your air pockets. So know the differences there. Respiratory bronchiole leads to the alveolar duct, leads to the alveolar sac, which is made up of the alveoli. And then the little circles, little perfect circles closed in, are the air pockets. The respiratory bronchioles are always going to be the biggest, and they're going to lead to the ducts that have the alveoli hanging off them. Just remember that. Capillary relationship with alveoli. So this is where respiration and circulation meet. Capillaries make a network on the outside of each alveoli, as you can see there at the bottom of the red and blue, right here with the little capillaries. Elastic fibers, these little yellow stripies here, we're going to talk about those a lot and when we talk about disease as well. Elastic fibers are the little stripes that prevent the alveoli from overexpanding, and they also help to swish air out of the alveoli. There's also smooth muscle that contracts in the bronchioles themselves. And sometimes bronchioles can get constricted by smooth muscle as you're trying to breathe. We call that asthma. Well, one of the things that can come up with that is called asthma. Super close-up of alveoli, where you can see the network of capillaries that overlay each one. So all these little windy, curvy things, all these little capillaries. This is under a scanning electron microscope, micrograph, super, super zoomed in. We won't see this in real life. Big universities have SEMs. They also have TEMs, another super microscope. But you don't need to know that. This is just a cool zoomed in image of alveoli and the associated pulmonary capillaries. So lungs, bronchi, and subdivision. So air passages undergo 23 orders of branching. So you start at the trachea, you branch into 2 primary branches, and then 5 from there, secondary branches. So remember, 2 to the left side, 3 to the right side, 5 total secondary branches. Then you branch again, then you branch again, then you branch again, and you branch 23 total times until you get down to the alveoli. And that whole branching thing, where we get smaller each and every time, is what we call the bronchial tree or the respiratory tree. You'll hear it called both. This is an anterior view of the chest. Know everything on this page. Be ready to have to label any of this on the exam. So the trachea is sticking out at the top right there. You'll recognize the difference between the trachea and everything else because of its ribbed edges. The thymus lies over the top of the trachea. The apex of the lungs are the tips of the lungs. Apex base is going to come into play again. We'll talk about more when I get down to the base of the lung. But the right superior lobe of the lung is going to be separated by this horizontal fissure that is between the superior and middle lobe of the lung. So note to label this horizontal fissure as the separation between the two. The right oblique fissure is gonna be what separates the right middle lobe from the right inferior lobe of the lung. The diaphragm right here, big old muscle, and then we have the base of the lung. So the base is the bottom, but that's confusing because the base is on top of the heart. Just remember that the base of the lung is the broad side, which is the bottom here, and the apex means the point or the tip. So even on the heart, the apex means the point or the tip. But it is confusing because the apex on the heart is on the bottom, but on the lungs is at the top. Just remember, apex means point. So the apex of the lungs is going to be the topmost part of the lungs. So apex is on top, and then base is going to be the broad side down here at the bottom of the lungs. On the left side, we have the left superior lobe, the left oblique fissure, and the left inferior lobe. So we do not have a horizontal fissure on the left side. Only on the right side does a horizontal fissure separate the superior lobe from the middle lobe. Where were we? Left superior lobe, oblique fissure, left inferior lobe. So that's only on the left side. And then you have this indentation on the left side, this little cutout section. We call that the cardiac notch. That's where the heart sits. And then in this little cutout section up here, a little zoomed in, you have the rib and the intercostal muscles above and below the rib. And just inside of that, right between the muscle of the rib and the lung, we have these little layers, this little lining. We have the parietal pleura on the outside, so closer to the ribs. We have the pleural cavity on the inside. So parietal pleura is going to be the first layer. We have the pleural cavity on the inside, which is a space, it's a cavity, there's fluid in there. We'll talk about later when we talk more physiology. And then we have the visceral pleura, the inside light color that lines the viscera. Here the viscera is the lung. It's our organ that the visceral pleura lines. And then again, we'll talk about this a little bit more later. Now this is a great visual of a respiratory tree on a lung that's been plasticized. So different colors of latex have been injected into different parts of the lung. Then the lung is dunked into acid to get rid of everything but the latex. So it's a cool visual of everything that we talked about, the different lobes, and the branching therein, right lung, left lung. Cool visual. And then this is a transverse section of the heart and lung. This is a good image of where the parietal and visceral pleura are specifically. Notice the proximity of everything. Notice where the aorta is, the heart, the pulmonary trunk, and everything that it leads to, and proximity of, the veins, pulmonary veins, arteries, where the lungs are. Always find the vertebrae on pictures like this so you can orient yourself to what it is that you're looking at. So this person is laying on their belly and you can kind of see right side, left side. Something else is to see which side the heart is sitting more against. Remember, it sits more to the left, so you'll know that this side's the left side as well. All right, now we're moving on to more of the physiology section. So how the lungs work, how they do gas exchange. So this chart is the inspiration event, the inhaling, the breathing in. And here you can see how the lungs and the rib cage actually change as you breathe in. So as you breathe in, the diaphragm is going to contract, pull down flat across. Here, it's still lobed, but if you're breathing in, boom, the diaphragm is going to be flat against the bottom here. So with that, it's going to suck air down into the lungs and cause your lungs to expand and elevate. Your ribs are flexible. They're going to move out, right? And then when you breathe in, your lungs get bigger, which allows for air or gases flow into the lungs until the intrapulmonary pressure is equal to the atmospheric pressure. And then that'll cause, that to end. So inspiratory muscles contract, diaphragm descends, rib cage rises, thoracic cavity volume increases, lungs are stretched, intrapulmonary volume increases, air and gases flow into the lungs until that pressure is equal to the atmospheric pressure. And then inspiration ends. Which leads us to expiration events. So expiration, exhaling, breathing out, it's the reverse, right? So then the diaphragm was flat, now it's doming back up, it's releasing, it's relaxing. The ribs are coming back down. The volume is decreasing in the lungs as air goes out. So remember the elastics in the alveoli. The lungs recoil passively with those. Read through these 4 again. And then get used to that. That'll be the end of expiration. It's basically the reverse of inspiration, right? If you flip between these 2 slides, this is what your body is doing all day long. Breathing in, breathing out, breathing in, breathing out, breathing in, breathing out, all day long. And you can see how anatomically that's changing there. But as you're breathing out, again, your inspiratory muscles relax, so the diaphragm rises, rib cage descends, cartilage returns back to normal. Remember, diaphragm domes up as you inhale, flattens out as you inhale, domes back up as you exhale. So diaphragm rises back up as you exhale. And then if you inhale, boom, it flattens back out. But it's a lot flatter than this picture shows. So anyways, we're breathing out. Our thoracic cavity volume is decreasing. Our lungs are recoiling passively in the alveoli. Intrapulmonary volume decreases. And then air flows out of the lungs. And it's pressure gradient until the pulmonary pressure is at 0. And then expiration ends. And that is what's happening if everything's working like it's supposed to. Let's talk about some problems that can arise. So one particular issue is called lung collapse, atelectasis. If you're going into nursing, you may have to be a translator between a doctor and a patient. So the doctor will call this atelectasis, but you will translate to the patient that that is actually lung collapse. Some doctors kind of stay pedantic, stay in doctor mode, and don't really know how to simplify things anymore. If you're going into nursing, you are going to be the person simplifying things for the patients. Lung collapse can happen from a couple different reasons. One is bronchioles get plugged up and cause the alveoli to collapse. When the alveoli collapse, the lungs collapse. Easy peasy. Not great. Second thing that can happen is pneumothorax. So this happens when there's a wound that lets air into the cavity between the parietal and visceral pleura. So there's liquid in that cavity that keeps the walls from sticking together. And let's say you get shot and the bullet penetrates the walls of the chest cavity and it gets into the layers of the pleura. Every time you breathe out, air is going to get sucked back in through that gunshot opening. So every time you breathe in, you're going to be able to breathe less and less air in because your lung is collapsing. So you breathe out, more air is sucking into that pleural layer, and it causes the lung to collapse bit by bit by bit. Think about, there's a hole in your lungs, you're trying to breathe in, but nothing's really happening. You breathe out, and there's air getting sucked through, and your lung is just collapsing because it's really not going to be able to expand or contract anymore, right? So that's an external cause of lung collapse, pneumothorax. Obstacles to breathing. So inspiratory muscles need energy to overcome 3 obstacles. Those 3 obstacles are airway resistance, which we will talk about individually in upcoming slides, alveolar surface tension, and lung compliance. We're going to talk about lung compliance a lot. So resistance number 1, obstacle number 1, airway resistance. So usually the amount of resistance in the lungs is pretty negligible. If there's a problem, epinephrine dilates the bronchioles and reduces air resistance. So if you have congestion and the bronchioles are tighter, your body would create epinephrine to open them back up. If it's too much for your body to naturally fix on its own, we go into something called anaphylaxis. So that's familiar, right? So bronchioles are so tight, there's no air going into the lungs. Obstacle number 2 is alveolar surface tension. So surface tension, the definition is that it attracts liquid molecules to one another where the gases meet liquids. Resists any force that tends to increase the surface area of that liquid. So in other words, surface tension tries to bind those water molecules together to keep you from separating the water molecules. So paperclip on this piece of film on water is causing this indentation higher than the paperclip, but the paperclip is not puncturing that film. So your lungs have that same type of surface tension too. Liquid in alveoli is called surfactant, and that keeps the alveoli from collapsing. So they'll never be flattened because they're filled with that surfactant. The alveoli is, and it keeps the lungs from collapsing. So what is surfactant? You can read through these. I'll read through them for you. Detergent-like lipid protein is made by alveolar cells. Surfactant reduces surface tension of alveolar fluid and discourages alveolar collapse. And then some infants that don't have enough surfactant can cause something called respiratory distress syndrome. So this happens in premature infants. Usually they don't have enough surfactant and they can go into respiratory distress. The third obstacle is lung compliance, and we've got a couple things here with lung compliance. So lung compliance is a change in lung volume that occurs with a change in pressure, distensibility, stretchability, if you will. If something is stretched, if something's opened, you're used to hearing it called distended, right? You've heard distended before. Some conditions that can cause the lungs not to be stretchy, smoking's the biggest one. So you're bringing in tar, you're bringing in heat. Something else, people who work in factories with a lot of dust, with a lot of fumes, a lot of particles, that can cause density in the lungs. That doesn't allow for stretch anymore. Tuberculosis, bacterial, histoplasmosis, fungal, or mesothelioma. The body's trying to fight these things in the lungs, which causes the lungs to be more fibrous. Something else that you've heard of is called more scar tissue in the lungs. That's going to reduce stretch, right? So all these are going to reduce your lung compliance. They're not going to be as stretchy as they were before. We just talked about this, but diminished by lung compliance can be diminished or worsened by non-elastic scar tissue, fibrosis, that fiber that gets built up, reduced production of surfactant, and then decreased flexibility of the thoracic cage. So reduced production of surfactant. If your body isn't making surfactant like it needs to, it diminishes your lung compliance because your alveoli isn't going to contract and expand like they should. Number 3, the decreased flexibility of the thoracic cage. So lung compliance is diminished by reduced flexibility of the thoracic cage. If the ribs are getting arthritic, right, they're not able to pivot as easily, then the lungs can only expand to where those ribs can rotate to. So that's going to cause your lung compliance to be reduced. There are also homeostatic problems that reduce lung compliance. Homeostatic problems that reduce might make it worse. Deformities in thorax, ossification of the costal cartilages, paralysis of intercostal muscles. So any changes to the shape of the thorax, ossification of the costal cartilages, so turning to bone, less flexible, getting more bony. Paralysis of intercostal muscles, your ribs aren't going to elevate the way that they're supposed to, right? So you can't breathe in as well. We just talked about this. Reduction in lung compliance is the result of all of these causes. Let's talk about respiratory volume definitions. Read these descriptions really well and read the average values. I'm going to give you the layman's terms of these. So tidal volume, that's the normal air that you're breathing in or out, but not forcing in or out. So that's just the normal air that you breathe in and you breathe out. Inspiratory reserve volume is the amount of air that you forcibly breathe in after a normal breath in. So you breathe in and then you breathe in some more. The additional air breathed in, that is your inspiratory reserve volume. Conversely, your expiratory reserve volume is going to be the same thing, but it's going to be breathing out and then forcing more air out. That forced extra is the expiratory reserve volume. Your residual volume is the air that's left in the lungs after the expiratory reserve volume. If you don't have any residual volume, then you have lung collapse. So there's always going to be some residual volume left in your lungs. There's one pulmonary function test that I'll talk about, and it's a spirometer. Know that a spirometer is the instrument that measures respiratory volumes and capacities when the doctors need to know how much you can breathe in and out. Non-respiratory air movements, that's nothing to do with switching O2 and CO2. So these are mostly results from reflexes. So examples are coughing, sneezing, crying, laughing, hiccups, yawns. I've probably coughed and yawned throughout this lecture, and I'm actually going to get a drink of water so I don't cough anymore. And so non-respiratory air's reflexive actions, not necessarily for gas exchange. So what is in the air that we breathe? So number 1 actually is nitrogen. 78.6% of the air we breathe is nitrogen. Second to that is oxygen, so 20.9%. Third is H2O, so this isn't in order. I wish it was. Third to that's going to be H2O. That's less than 0.5%. So that's water vapor. And then less than 0.05%. So 0.04% of the air that we breathe is carbon dioxide. Know these approximate percentages. Standardized tests might have you put these in order from most to least or from least to most. So know nitrogen, oxygen, water, carbon dioxide. Or conversely, least to greatest, carbon dioxide, water, oxygen, nitrogen. But know these percentages. Basic properties of gases, Henry's law. So when a mixture of gases is in contact with a liquid, each gas will dissolve in the liquid in proportion to its partial pressure. So CO2 is dissolved in water as carbonic acid, that's in the blood. Then it gets converted back to bicarbonate and then back to a gas as we exhale out. That is the part that you need to know. So CO2 dissolved in water or our blood is carbonic acid, and then it's converted back to bicarbonate and then back to CO2 as we exhale. The amount of gas that will dissolve in a liquid also depends on its solubility. So CO2 is 20 times more soluble than oxygen. So you'll get 20 times more CO2 dissolved in blood than you will oxygen, or a faster rate, I should say, because it's more soluble. So think about the consequences when you're trying to get more CO2 in, or more oxygen in. Think about the consequences when you're trying to get more oxygen in, but your CO2 attaches more easily. We'll talk about that in a second. Very little nitrogen dissolves in water, so nitrogen's not really binding into your blood as well. O2 and hemoglobin. Loading and unloading of oxygen is facilitated by the change in shape of hemoglobin. So in order for oxygen to attach, that means hemoglobin has to be able to change shape. And when you have weirdly shaped hemoglobin, then your oxygen's not going to load or unload correctly. Think sickle cell anemia. Think how problematic that is. We've talked about it before. Those sickle cell shapes are not going to bind oxygen as well. But hemoglobin that has a normally shaped red blood cell can be fully saturated. So fully saturated, all four heme groups, as long as everything's shaped correctly, carry O2, you're at 100% saturation. When you go to the doctor, they put a little clip on your finger. That's what they're checking for. You will never be at 100% saturation, but you'll see a normal level of mid to high 90s as percent saturation of O2 and O2 saturation, if you will. So more homeostatic imbalance is hypoxia. We've talked about hypoxia a lot. Hypo, low oxygen, low oxygen. So this is due to a lot of things. Inadequate oxygen delivery to the tissues can be caused by a variety of things. Low red blood cells due to injury, due to your bone marrow not making enough. Your spleen is taking your red blood cells out of circulation too quickly, maybe. It can be due to abnormal, so sickle cells, or too little hemoglobin because of abnormal sickle cells. Could be due to blocked circulation from blood clots. Could be due to metabolic poisons, pulmonary diseases. A metabolic poison here is carbon monoxide. I've got it on here twice. You could have carbon monoxide coming from a gas leak. That can cause hypoxia. Influence of carbon dioxide on blood pH. CO2 in a liquid changes to carbonic acid. If you have too much CO2 dissolved in blood and you're turning your blood acidic, I just gave you the answer. Is it going to be more basic or is it going to be more acidic? Too much CO2 dissolved in blood is going to be acidic, right? This is what we call respiratory acidosis. So it's lowering the pH, so it'll be more acidic. So shallow breathing can allow CO2 to accumulate in the blood. That's what we call respiratory acidosis. Depth and rate of breathing. Hyperventilation is going to help you breathe off excess carbon dioxide. So if you're going through respiratory acidosis, your body will make you breathe faster and cause you to hyperventilate to get oxygen in and carbon dioxide out. Apnea is going to be the opposite of that. So you'll stop breathing temporarily to increase your oxygen intake, so that can kind of balance out in your blood. If you're hyperventilating because you're anxious, it'll increase your CO2. If you're breathing into a bag, it'll help you recirculate your CO2 to stabilize your pH. If you don't have a paper bag to breathe into, hyperventilating can cause you to Hyperventilating can cause you to pass out, so you won't be blowing off extra CO2 and you'll be building it up more naturally. Can freak people out that are around you, but hey, you'll get into a more stable realm. Respiratory adjustments for high altitude. You can develop something called acute mountain sickness from traveling to elevations of 8,000 feet or higher. All of these symptoms can happen: headaches, shortness of breath, nausea, dizziness. In really severe cases, something lethal can happen, which is cerebral edema, so swelling in the brain, or pulmonary edema, swelling in the lungs. Acclimatization to high altitude, we've already talked about in previous lectures, but your body's getting used to it. Respiratory rates are going to change. You're going to breathe more, and eventually your body's going to increase the amount of red blood cells to overcompensate for the lack of O2 intake. So decline in O2 can stimulate the kidneys to accelerate production of erythropoietin, which is what stimulates the making of red blood cells in your bone marrow. And like I just said, red blood cell numbers are going to increase as long-term compensation for factors that are environmental. COPD, chronic, not short-term. There's a blockage somewhere there. It's an irreversible decrease in getting air out of the lungs. So most patients with COPD, 80% are smokers. There's also the fibrous tissue that we talked about, the scarring that can happen, dyspnea, which is labored breathing or shortness of breath, too much scar tissue, lack of lung compliance, shallow breathing, increase in carbon dioxide in the blood, more acidic. All this can lead to respiratory acidosis. So read through these. It's irreversible, not great. This is steps to bronchitis and emphysema. You can read through these in terms of tobacco smoke and air pollution. So focus on tobacco smoke and air pollution and what that can lead to. So in chronic bronchitis, it can cause tobacco smoke and air pollution can cause continual bronchial irritation and inflammation, leads to chronic bronchitis, which leads to airway obstruction, which leads to abnormal ventilation, hypoxemia, hypoventilation. So the opposite of hyper, right? Hypo, low oxygen. Conversely, with emphysema, breakdown of elastin and connective tissue of the lungs as related to tobacco smoke and air pollution. Get emphysema, read through that. Airway obstruction, shallow breathing, hypoxemia, hypoventilation. Some people with emphysema, let me go back for a second. Some people with emphysema, if they're trying to overcome it, you'll see them fold forward to force more air out and lean back to get air in. So they're physically pumping air in and out because their lungs won't do it anymore. Their lungs are shot. Asthma, airway inflammation, usually due to allergies. Eventually, airways thicken and don't stretch very well. This is super common. Also causes shortness of breath. You can read through this, bronchospasms, etc., etc. Tuberculosis, you don't hear much about it anymore. It's an infectious disease by bacterium. Symptoms include horrible coughing, all the way up to spitting up blood. People with it would undergo 12-month course of antibiotics, and some wouldn't make it all the way through. They would die before they ended their 12-month course of antibiotics. Highly communicable, transferred by air particles. That's why if it happened in a household, all the family would get it. And then lung cancer. So read through this. It's the leading cause of cancer death in North America. 90% of all of these cases are the result of smoking. 3 of the most common types. Your number 1 most common type is going to be adenocarcinoma. It's in the lung tissue. Second most common type is the squamous cell carcinoma in bronchial epithelium. So it's the lining of the bronchioles. And then your least common but the worst one is small cell carcinoma. So it contains lymphocyte-like cells that originate in the primary bronchi and subsequently metastasize. They go throughout your whole body. They spread the worst, and small cell carcinoma is pretty deadly overall. And that's our lecture.